Death. How does that topic make you feel? Do you fear it? For most people, death is a conversation they leave to the last minute, when they're old or when they're faced with an illness. Wills are rarely written by young people. But it's time we spoke about death more than in hushed tones, because ignoring it, brushing it under the carpet, or fearing it, it's not good for us. If we understand death, we can learn to live better and, when it comes to it, die more peacefully. I'm Dr. Karan, an NHS surgeon, and in this podcast, we cut through the BS of modern health advice and tackle the biggest issues in science and medicine. Julie McFadden, known as Hospice Nurse Julie on social media, works to alleviate the fear and stigma around death and dying. In this episode, we touch on the science and biology of what happens in the months, weeks, days, and hours before death. Why some medical interventions hurt more than they help. What hospice care is really about. Some of the odd phenomena that happen, like patients seeing dead loved ones, the most common deathbed regrets, and why death isn't the worst possible outcome. Enjoy! So, Julie, this is quite an unusual topic for a podcast, talking about death. It's something which a lot of people fear. And I stumbled upon this quote by the great American writer Mark Twain. He said, "I do not fear death. I had been dead for billions and billions of years before I was born and had not suffered the slightest inconvenience from it." And I heard that, and it makes sense to me, but it also makes sense why people are afraid of death, because they may not see it on a daily basis and they just have it at arm's length. They see it on the news. Why is it, do you think, people really fear death? And why is it that some people don't?
Well, first, I love that quote. I've never heard it. And I think about that all the time. I always think about, I believe there is something after death. But if there isn't, that's okay too, because I'm not going to even know. So what's it to me, right? But I think there's so many reasons why people fear death. I think the ultimate one is just the great unknown. People don't like to not know things, including myself. We want to know all the things so we can feel safe. And we don't see it every day. So it's easy to pretend like it's not going to happen, ever.
Yeah, you're right. And I would say even for healthcare professionals like yourself, like myself, who might see death slightly more frequently than the average person. I remember when I saw my first real death where I was involved as part of the team looking after the patient, involved in that death. Even though I'd seen and heard of death before in the hospital setting, it still struck me. That first time doing CPR on an elderly patient, breaking the ribs, really visceral feeling of all of this panic and chaos going around. And ultimately after, sweating, trying to do the cardiopulmonary resuscitation, the patient not making it through, that left me feeling a certain unusual way for weeks. Like it lingered, that feeling.
Oh yeah, I get it. As a hospice nurse, which I've been for the past 8 years or so, it feels a lot different. But I was an ICU nurse and an ICU trauma nurse for 8 or 9 years before that. And my experiences there, people think hospice nurse is depressing. I'm like, you guys have no idea. And I think specifically with CPR, I have the same thing where I can remember the people I have done CPR on, because there's something so traumatic about it. And there's a right place and a right time for that, I think. And then there's times when we overdo it as a society. Hence why I feel like we need to educate about what it really means to resuscitate somebody. Why do we preserve life at all costs when death is inevitable? And I think we need to start reframing that so we don't have those chaotic moments of doing CPR on a 92-year-old. Again, that's a whole other topic we can get into. Everyone's allowed to have their rights. If they want it, they can get it. But I think if they knew more about it, people would not always be saying, yes, do this for me.
Why do you think it's important that people acknowledge death more in their lives? And I guess it's difficult me saying this, but trying not to fear death. Why can that improve someone's life or quality of life?
So I say this because of my experience as a hospice nurse. And after years of experience of being a hospice nurse, the patients who were willing to discuss and talk about their death, even in a negative way, even in a way of like, I'm afraid, I don't want to, I'm angry, they seemed to have like a lightness and like they lived better. while they were still alive. And their dying process, which does take a longer time, usually on hospice, seemed easier. Less medications were given, less agitation, less pain, like all physical symptoms, but then also less emotional pain, all because they spoke about it. So I don't know if it's about like not fearing it or just fully accepting it, but there's something about discussing it and being honest about how you feel about it that seems to help people. And really, it usually releases the grip of fear, even a little bit for a moment, which can feel good.
Do you feel a lot of our societal conceptions about death are actually harmful? Like we take a look at in the Western world, classically we see the Grim Reaper, skeleton-like form, cloak, hooded, massive scythe, seen as like this embodiment of fear and something which you never want to see. Then he comes and, it's kind of like this humanized figure almost, which is malevolent. And that's quite a harmful notion to process death as malevolent, where it's just a natural process which has no bias.
Wow. Yeah. I've actually never thought about that. That's such a good question. You're right. I think we really need to change the way we look and how we feel about death and dying, because the way we are doing it now, it's like we deny it at all costs until it's right in our face. And then because of that, we struggle. I'm not like anti skeletons but it's also like, yeah, why aren't we making death more about flowers and life and the beauty of a full circle? You're right.
Do you think that is something that is uniquely Western, where it's a sort of a Western philosophy where there's a clear boundary between life and death, heaven, hell, and all of these things which may or may not happen, and this kind of maybe more puritanical beliefs? And then you compare to other religions, like, my family are Indian. I was brought up in a Hindu household. So in Hinduism, there's a more spiritual feeling about death, reincarnation, and the god of death is sometimes even prayed to. Yama, the god of death, is prayed to for longevity and to stave away illness and death. And it's more a holistic approach to looking at death as, like you mentioned, this cycle where actually it's a process of renewal. And even, beyond Hinduism, in other cultures, particularly in Southeast Asia and even in Mexico, where they've got the Day of the Dead celebration, where, every year they kind of worship the dead in some way and they're part of the dead again. They come back to spend the day with their family every year. Is that a nicer way, do you think, to destigmatize death? Is that a better way of thinking about it? Or do you think it not has any significance?
I think I love the Day of the Dead one. I think it's great. I love learning about other cultures and how they celebrate life, because ultimately that's what it is. It's like, even though we're talking about death, they're celebrating life. However, I will say I've only been a nurse, in the US, right? So I only have that as experience, but I am in Los Angeles, so I see all different cultures. And across the board, culturally, for the most part, people are afraid, maybe not even afraid, but like death denying. Even if they say they're not afraid, they still think it's over there somewhere, right? They aren't, it's not here yet. There's something about like the denial of time and death that seems to, at least in my experience with people on hospice, many times, there's still this denial of like, it's happening, but not really. We'll talk about that later on. Maybe in a couple of weeks when it's really bad, whatever that means, right? So I think there's still something about like, and I think it's more about true education of what end of life actually looks like. It's multifaceted, right? But generally speaking, I think the changing how we feel about death will come with true education of what end of life looks like. And just talking about that openly, broadly, that it's going to happen. How's it going to look? That will change things.
What do you typically see in terms of the process of dying biologically? What's happening to a person in the weeks and maybe even days and hours leading up to the point when, their light is extinguished?
Yeah, so I want to first say that my mind was blown when I first saw someone die on hospice. versus someone dying in the hospital in the ICU after a very prolonged ICU stay of us trying to keep them alive. Those deaths look very different. And when I saw my first death on hospice, I feared death so much less because I was like, wow, you could see how doing nothing to the body and allowing the body to just naturally die, like there are things that our bodies do to help us do that. So the main things I usually see the first 3 months or so before they die is a lot of sleeping and not a lot of eating, not a lot of drinking. And that's really it. Like, and those three things, if you just sort of allow the body to be the guide, it will start guiding the body. The body will start sleeping more than being awake. So there'll be more sleep than they are awake. They'll barely eat. They'll barely drink, if at all. And of course, because we live in a society where like that seems wrong, people are up in arms with their loved ones. You have to eat. You have to eat. And it's like, no, you don't have to eat. And really the people that know that and will listen to their body, again, live better while they're alive and die more peacefully. So there's many things that go on, but those are the three main things. They don't eat and drink and they sleep all the time.
And do you think those things that you mentioned there, those kind of core symptoms, is important to educate other people or kind of the lay person who doesn't really know much about death?
Yes.
To kind of learn that actually this is how it all begins.
Yes. That's why I've taken to social media in the first place, because I just feel like so many people don't know, including other healthcare workers. I didn't know as an ICU nurse that giving people fluid at the end of life is harmful. I mean, we pump people full of fluid and then we fluid overload them and then they go into respiratory distress. Then we intubate them. Then we diurese them. Then we hurt their kidneys. And it's like that cycle over and over again. Right. And so I didn't know at the end, like when someone truly was at the end of life and they wanted to die naturally, giving fluids would harm them, really make it worse. So it's just things like that. It's like, even as a experienced nurse, I didn't know some of the things I know now. So yes, education is key for everybody,
In addition to someone, I guess, in the weeks leading up to the death being kind of powered down version of themselves, is there something more to the biology? Is there more sort of signs and symptoms that happens on a biological level, like organs one by one kind of shutting down and seeing that happen in a cascade?
So I wouldn't say it's like that, but the actively dying phase, which is the last phase of life, is where most people where most families who are watching their loved one, not the person dying, but the people watching, become afraid, because the person really does look and act different in the actively dying phase. And what we've seen in the movies is someone laying in bed looking beautiful and like giving a big monologue of their life and then like closing their eyes and falling asleep and dying. And that is just not ever how death usually works. So the actively dying phase is the most distinct, the most obvious, which is they're fully unconscious. Their mouths are usually hanging open. Their eyes can be open, but not making eye contact. They'll have changes in breathing, which is like what freak people out a lot when they see it. They might have like a noisy breath. So like terminal secretions, or it's called like the death rattle. Changes in temperature, changes in skin color, like they're going to look different. And it can feel a little scary. And the way they're breathing can even look like they can't breathe. They're gasping for air, and really it's Cheyne-Stokes breathing or agonal breathing. It's just happening because of their blood chemistry is changing because they're dying, right? So it's making them breathe different. And for the most part, you can tell they're comfortable by how they're laying there. Because if a dying person isn't comfortable, they're like a baby. They'll be restless. They'll be agitated. They'll be rolling around. Like you'll know that they're not okay. So those are the main points that I think people need to understand, that your loved one can look like that and they're not suffering. I think a lot of people, they just don't want their loved one to suffer. So when they see this and they don't know what it is, they assume it's suffering.
And do you feel that, I guess there's also, I mean, I had this misconception as well before I started medicine, where I would think that end of life or palliative care, when you involved the palliative care team, that would mean that's it, it's done. But actually, there are roles aside from death for the palliative care team. It can just be for comfort or pain relief.
Yes, exactly. I mean, I think palliative care should be started like the second you get any kind of life limiting, or, I mean, we can say terminal, but like who knows, right? So any kind of life limiting disease, I feel like palliative care should be like started right away, because they're looking at the person as a whole. They are looking about like how to make your quality of life the best it possibly can be with this life limiting illness. So I think we need to shy away from like thinking like, don't start palliative care yet. Hospice is a little different because technically you have to like qualify for hospice and have 6 months left to
Yeah.
live, and you can't do treatment. And so things like that. But I do also think hospice needs to be reframed as well, where it's like, sometimes there isn't anything else to do. And maybe the best thing to do will be go live your life while you still can. You know, I think a lot of times we need to have a little, we need to be less afraid. And I know it's easy for me to say because I'm not the one saying this, telling people this, but be less afraid to say, hey, I've seen people with your disease, for years and years and years, and you are probably going to die in 6 months. I think it's important that we do start doing that, because what I think people hear, because they're so afraid of death, is the person who says, you likely are going to die within 6 months, but here's what we can do. And I know there are things we can do, and I'm not saying we shouldn't say that, but I think people really need to know where they stand, because all they're going to hear is, here's this thing we can do. Maybe it'll help a little bit. And by a little bit, we say get you sick for the next, especially with certain diseases. I really am passionate about certain diseases. I think we're not really helping. We're making them sick for the first 3 months, and then they finally stop doing it, and then they're alive for another 3 months, and then they die. And I just think it's unfortunate.
Do you think, given that we could maybe even say that death isn't necessarily the worst outcome?
Yes, I always say that. Death is not the worst outcome. Suffering is far worse. And you and I both have seen that with our eyes. You know what I mean? I mean, I've seen the most suffering I've ever seen is being an ICU nurse and keeping someone alive who is definitely already dead through multiple machines, because no one, and again, I'm part of it. We weren't able to really say the truth, which was, they're not coming back from this. And even if they do, so I'm thinking of one specific patient. He had metastatic pancreatic cancer to start with. And then we kept this person alive on multiple machines for 6 months to maybe get out of the ICU to then start treatment for pancreatic cancer. Like, what are we doing? Why are we doing this to people? That to me feels literal, like a wrong, like we wronged them.
And I think giving this sort of choice to patients, based on what you've said, I guess it gives them the option to almost decide when they're going to die. Patients can refuse the treatment options and decide, you know what, I don't want that. I want to die on my own terms at this point. And that gives them more power and more control over their death, which I think is important, right?
Right. Yeah. Yeah. And I think if I got diagnosed with metastatic pancreatic cancer, because of what I've witnessed, I don't think I would do any kind of treatment. I think I'd be like, okay, there we are. Like, here it is. You know what I mean? And I think, and again, someone else might, who knows? And maybe I would when I was really faced with it. But my point is like, so many people who are not in healthcare don't understand. So they're only listening to what we say. And I think it's just so important that we give them all the options. So like, we could say all the things we could do, but we also need to talk about hospice and end of life, and not treat it like, or you could go on hospice and die, because that's not how it is. I mean, you're going to die either way. So which one?
Yeah.
Which one do you want? You're going to die either way. They're looking at hospice as death and treatment as life. And that is not necessarily true.
Yeah, no, I agree. I think in traditional medicine, we have this dichotomy where it's very black and white. We can treat you. And with the option of treatment, we give the patient sometimes a lot of false hope, and we potentially subject them to that suffering you mentioned. And we might even speed up the timeline of death by doing all these interventions, or worse, prolong their life, but it's more suffering in that prolongation of life. And yeah, we often do undersell the benefits of keeping someone comfortable in a hospice where they can maybe have capacity to a longer degree of time. They can be around family, make their wills, make their plans, and go out in their own way. I mean, one of my old surgical bosses kept drumming this into me, and he said, a good surgeon knows how to operate. A better surgeon knows when to operate, and the best surgeons know when not to operate. And I've been faced countless times in my career with very elderly patients who've got some sort of pathology, whether it's a perforated intestine or some sort of dead bowel. And there's a choice that you can make right then. You tell the patient, listen, an operation would most likely work, but also there's a high likelihood it could kill you within 24 hours or a week, but you'd be unconscious, intubated, ventilated for a week and then die. Or we could give you antibiotics, keep you really comfortable and as pain-free as we can, and you might survive 2-3 days, but you'd be awake with your family around you, etc.
Wow.
And it's having that uncomfortable conversation which is allowing them to say, do you know what? We should not do surgery. You know, I think sometimes as professionals, we're too afraid to actually give them the uncomfortable truth and saying, you need to do this, basically. This is what I would advise. Like if I was you, I wouldn't want the surgery, even if there's that 10% chance of it succeeding, because in all likelihood, it's not going to work.
Yeah, even you saying that to me in the moment, I'm like, ooh, but because it is hard, but it's like, that to me is what needs to be done, And then they can choose, right? They still have the right to choose. And they can still say, no, do it. It's like, okay, at least I know that they know.
And why do you think we have this obsession with euphemizing death? You know, like in the UK, we have certain words like, God's waiting room. People say passed away, or rose cottage for when someone's about to go. And there's all these kind of weird ways to really euphemize and use these euphemisms to just make death a little bit sugar coated. And we don't want to mention the D word.
I know.
Just like people say with cancer, you've got a growth, you've got some sort of neoplasm or whatever. They try to get rid of the C word, and now it's the D word. We don't want to talk about death or dead.
Yeah. I have a whole chapter in my book called "Death is Not a Dirty Word," because, and I think it's probably just been over time. People, it feels a little nicer to say like they passed away, they are gone. And you're like, gone where? What happened? And I think it's just going to be a matter of trying to change that by starting to say it more. And it starts with healthcare workers, people who are here every day saying we have to get comfortable saying that too, and trying to teach other people that death is not a dirty word. You can say it. You can say he's dying. You can say they've died, and it hurts your heart a little bit because you're not used to hearing it. Everyone plays a role in this. Even me, who's like totally on board with saying death, dying, dead, and I'm around it all the time. I get it. It still kind of hurts a little more when you say someone's dead versus they've passed away. But we just got to get used to it. It feels harsh, doesn't it? It feels harsh.
On the tongue, it feels very harsh.
Yeah.
Like, how's so-and-so doing? Oh, he's dead.
Yeah.
It just sounds very kind of abrupt.
Yes. And I just think using the word over and over, we have to kind of desensitize ourselves to that word because we've made it a bad thing.
It's kind of like when you see things on the TV and movies, right? People are almost desensitized to death when it's on screen. And some people even love death on screen, true crime, horror, yes. People love that stuff. But when it's facing them in the real world, it's a complete, night and day. Somehow that same love they share for crime and horror and serial killers and horrible death doesn't quite add up to what they see in real life. But yeah, maybe it is kind of talking about it a bit more, or, even when someone checks into the hospital, having some sort of form where you got to, if you do you're on the verge of death, what would you want kind of thing, kind of getting that into the culture a bit more,
Yeah.
I don't know how it's in the US. I guess it's somewhat similar to the UK, where most elderly patients in the hospital who are admitted for a period of time, we have to, if they don't have a do not resuscitate form or a DNA CPR form in the UK, one of the doctors needs to have a discussion with that patient to basically say and ask them, do they want to be resuscitated or not? This is assuming they don't have a form from the community or a pre-existing hospital form. And that conversation has always been really awkward because essentially what you're telling the patient is, if you die, do you want us to try and bring you back from death? And if you ask most people that on the street, they'd say, hell yes. If I die, I want you to try and bring me back. But actually, that's not as simple as it is, because these are patients in their 80s and 90s with heart failure and dementia and all sorts of things. And if they did die and we brought them back somehow, even if it was successful, for want of a better word, they would be probably in a comatose state or, at best, quite disabled.
Yep. So we do that as well. And I like that we do that. At least we do it, right? But I do think, unfortunately, what physicians and nurses in the hospital don't have is time. And I think conversations like that take time, and they don't have it. So it has to be this awkward conversation of like, okay, I got to check this off my list of things I have to do today, right? And you try to do it as well as you can. You're just meeting the person. How do you start the conversation? So it turns into this like weird, awkward conversation where a lot of people will just go, no, I'm full code, bring me back, because they don't get it. And it's hard to have that harsh kind of conversation about like, listen, this is what it means if we try to bring you back. So, I mean, I'm glad we do it. At least we do it. But it's like, it's also, I feel bad for, healthcare workers, especially in the hospital. You guys don't have time to do. I mean, and things like that take time.
One of the strangest things I've seen, one of the strangest phenomena that I've seen when I'm witnessing a patient who's, palliative and end of life, was this brief period of normality, this almost terminal lucidity when they're dying, they're really unwell, and suddenly they seem that they're fit for discharge. They're talking normally. They're maybe even eating. And we kind of think to ourselves, hey, are we doing the right thing by putting this patient as palliative? Are they actually ready for surgery now? Are they ready for, physio? Who knows? And then the next day they just, end up dead or severely just deteriorating even worse than the previous day. Number one, why is that? And number two, is that quite a common thing to see?
Yeah. So terminal lucidity is like 1 in 3 patients, like 30% of all dying patients that happens to. So it's like close to the number 1 or number 2, like phenomena that happens at the end of life. And we don't know why it happens. There's always theories about like, is it a burst of cortisol or like it's like something like giving one less jolt of energy to people, but no one really knows, but we just know it happens all the time. So I always try to talk about terminal lucidity or like the rally or the surge or the nicknames of that to families. So when it happens, they kind of know it's happening so they can appreciate it in real time. Because a lot of times you don't know someone's having the rally until they're dead. Right? Until after it's over. When I became a hospice nurse and started seeing all of this crazy, just crazy stuff that like I would never as an ICU nurse have believed unless you see it with your own eyes. And then on top of that, you start seeing it with your own eyes all the time.
What other weird phenomena in the end of life phase have you seen?
The other one that I see all the time is visioning, where people see like dead relatives or dead loved ones, like old pets that have died. I see that so often that like it's hard to even like recall a certain time because it just happens all the time. People see their dead parents, or it's always people they love. So if you didn't love your parents, you probably aren't going to see them, but it's always people that they love and they are excited to see. And many times those people who are seeing the dead people are very alert and oriented. They're not like drugged up and on the verge of death. It usually happens like 3 weeks before death. So they're like up walking, talking, and they are seeing things that we aren't seeing. And then every once in a while, I'll see someone who basically like chooses when they're going to die. So they basically will say, I'm going to die after this date, or I'm going to wait for my daughter's wedding. Or I've literally had a patient say, I'm dying tonight, and then die, even though they weren't actively dying.
How?
I have no idea. And they did not take anything. They did not do it. It was like, I could not believe it. Jaw on the floor. Like, what the heck?
Wow.
What the heck?
Wow.
Yes. So the bodies are crazy, man.
You mentioned that, I guess, most people who are kind of living a good life can have a good death in terms of, their body slowly shutting down and showing that kind of those core signs of more sleepiness, less hunger, etc. Is there anything that someone can do in their life to continue to, ensure they have a good death and maybe not so much a violent death?
Yes, I think. So one, I want to preface this because many patients are popping into my head right now who are beautiful people and they had a harder death because of specific diseases. So there are specific diseases that are just hard. And it's nothing to do with whether you're a good person or a bad person or if you talk about it or not. Like sometimes you just need to be palliatively sedated because this disease is tough and it sucks. So that I just want to say that. And then two, but generally speaking, I think you need to be willing to ask for help, like accept help. You need to be willing to let go of how your life was because your life is going to change drastically and you're not going to be able to do the things you used to do. And that's really hard for people. And I'm saying this to myself because I know that I would have a hard time with this. I'm like neurotic. I want to be in control of everything. I want to live in the black and white. I want to know what the deal is. And a lot of times end of life is very gray. So you don't really know. You have to ask for help. You have to get help. You have to accept help. That's really hard for me. And I think you have to be willing to talk honestly about how you're feeling, honestly, not just like what you think you should say, but no, how you actually are feeling, because that will help tremendously on the letting go process. So for me personally, because I know I would have a hard time with all these things I'm saying, I practice it in my life now. I practice now trying to live more in the gray. I practice now being able to accept help, appreciating the life I have, knowing that it will end someday. So it's a combination of things, but your personality does play a part in how you die. And I tell that to myself because I know I'm like anyone super controlling. Whew, you gotta try to let that go. You gotta try to let that go. I don't.
Sounds like me as well.
I
mean,
know.
I overthink things, like OCD about details, before surgery and stuff. Yes. So maybe I need to start living in the gray a bit more.
Yeah. I mean, don't we all? Don't we all? And it's just a process. It's just a process. And guess what? If you are on hospice, you have a whole hospice team to help you. You have professionals who do this day in and day out. There's a chaplain who most people will deny the chaplain because they're not religious. And it's like, no, this chaplain is an amazing person who's just there to help you. Just let them help you.
Like a therapist.
Yes.
Almost.
Yes. A free therapist. Let them come over. Let them hang out. So there's a chaplain, there's a social worker, the nurses are usually great, CNAs, doctors, we're all there to help you.
You mentioned also about some of these other diseases which are pretty petrifying when it comes to end of life. What's an example of some of these?
So let's see. I mean, ALS, I think, is pretty tough. So ALS is a tough one. And that's just because, you eventually feel like you can't breathe. And if you don't want a trach and be on machines, you have to be sedated because you're going to feel like you can't breathe. End of story. And that's how your death would. So many people, we do, not everyone, but many people with ALS, we will palliatively sedate so they don't feel like they can't breathe. I had a patient recently who had a small bowel obstruction because of a tumor, and he was done getting an NG tube placed because, we could just place an NG tube, put suction so he doesn't feel so nauseous and he's not throwing up all the time. But he was like, I'm over that. I've done this 3 times. I don't want it anymore. So he was violently nauseous and vomiting, just 24/7. And that's the kind of stuff that's you just need to sedate someone like that. It's you're either awake and miserable because you don't want interventions, or you're asleep and not. So those are the times. Those are few and far between, but there are things like that where it's they're not doing anything wrong. This is just tough. it feels painful. It feels bad to have your bowel obstructed. End of story.
Yeah.
Right.
Yeah.
So it's like those types of things. Glioblastomas, anything with the brain, that can be tough, but there's definitely things we can do. It just takes a lot of medication and things. And sometimes people, families will say, well, we don't want to just sedate them, and I get it because they want their loved one there. But you're kind of like, they're either awake and uncomfortable or they're asleep and not. And that's unfortunate, but that's the truth. And you do want to sedate them because no one wants their loved one to suffer.
It's interesting you say that about the patient with the small bowel obstruction and the nasogastric tube inside. And it just makes me wonder sometimes, are we doing too much to patients? And often as healthcare professionals, we don't know the true impact of those interventions because we haven't faced them ourselves.
I know.
I unfortunately subjected myself when I was a medical student to having a nasogastric tube done just to allow my friend to practice, but also so I could see how bad it really is. And I thought, it can't be that bad. It's just a tube going down the nose. It was horrendous. It made me gag, made me painful. I felt like I couldn't breathe. So every time from then on, I put an NG tube into a patient, I felt the pain with them in some way because I was like, this is terrible. And I know it's terrible. And I always used to try and find ways to make it more bearable. Like I used to put the nasogastric tubes in the freezer so they're a bit harder so they don't bend too much. And that seemed to help. Give them some like flavored water to drink as they like sip as they go down. Just little tricks. Because I realized how bad it was. And it was only until I walked into a job where I just started the job and there was a patient already on the ward who was end of life. They'd been end of life for 2 or 3 days. And the next day I was in charge of doing the ward round. And I did the ward round and this patient was end of life, but still had daily blood tests done for them and booked for them. They still had a bunch of medication that wasn't really needed. They were on antibiotics. Like, what's the point of antibiotics if someone's end of life that you've decided? They were on things like omeprazole. They were on things like Gaviscon. They were on statins, heart medication. I'm just thinking, wow, I mean, so much side effects and interventions and pain and suffering when we've already said this person's end of life. And it just makes me think sometimes, do we do too much? And like you said before, should we just let the body do its thing?
And I think too, a lot of that comes with education because I know a lot of times, and I don't know the situation and your circumstance, but a lot of times healthcare workers don't know how to talk to the family about how to stop those medications. So the family just hears, oh, what? Now he's dying, so you're just stopping everything? And it's like, no, it's not because of that. It's like, it's worse. Why make him, her, take all of these meds when there's tons of side effects and there's not a benefit? It's risk versus benefit. What are we doing here? It's not because we don't care anymore. We're just stopping all the meds. It's like, we care. So let's pull back on some of these things.
One of the reasons why I really wanted to have a chat with you about this death is something that I've seen more and more over the years because we don't talk about death much, particularly in the Western world, when it comes to that end stage, the family are in a panic. The patient, if they're still compos mentis and alert, maybe in a bit of a panic as well because, it's caught them off guard. They've got this new diagnosis or they're really unwell. All of a sudden, it's an emergency thing and they haven't done an advance directive. They haven't sorted out their life. They haven't decided whether they want to be for resuscitation or not. There's all these things up in the air. And it's only, like you said before, when it's in your face, you're like, oh God, I've got all these decisions to make. And maybe that's why we should be more cognizant of talking about death earlier on when you're actually well and hale and hearty to make those decisions not under duress, not when you're stressed and worried about everything or anxious or pressured by family to do certain things, because if the doctor comes to you and says, do you want to be for full escalation? Like, do you want to be intubated and ventilated, ICU, kidneys filtered, etc.? Your family are going to be like, yes, because they don't want you to go. But you're the one that's going to have your kidneys pumped and then your kind of blood taken away every day and plastic tubes down your lungs. You're the one that's going through the suffering. So actually in that situation, you might just be like, yeah, I want everything. And you might not be so vocal. And I just feel that's why we need to talk about death earlier. So like, maybe one day when I'm in my 50s and I'm still feeling good, I've got my family, I want to start thinking about death really then. So when I'm in my 70s or 80s and, touch wood, If I end up somehow in a hospital, it's already made. The decisions are already in place, and it's more relaxed.
Yes. I mean, that is my whole mission on being on social media and having my book and trying to talk to the general public about why it's so important to think about these things and talk about these things. I'm 41, and of course my directives will change as I get older, but I'm 41 and my family knows like what I would want, what I would want if something were to happen to me. And again, that'll change as I get older. Now I'm healthy and I'm 41, and if I pass out in the mall and my heart stopped, yes, I do want resuscitation, but that will change, but at least like my family knows this, right? And they know that if what I'd want if something happened to me and I was prolonged, if I was in the ICU for a prolonged period of time. Anyway, my whole point is saying this is you're never too young. Like you like talk about it. Everyone should be talking about this. I mean, this is something that if you think about it, we plan for weddings, we plan for new jobs, a move, a date. We plan for all a vacation. We plan for everything, but we don't plan for the one thing that's guaranteed, which is death. Like, why don't we plan this? Why don't we talk about it? I don't understand.
And, given that we don't plan for some things in life, what are some of the most common deathbed regrets that you hear?
The first one I hear all the time is that they regret not appreciating their health while they had it. So that's the number one thing people say to me. I wish I would have understood how amazing it is to have a working body. It's like, yeah, and that really sits with me. And I really try to remember that every single day of my life while I have a healthy body. Second one is usually they work too much. So don't work your life away, which is really easy to say, but I know it's hard not to when you have bills to pay and things like that, right? But most people regret that. And then the third thing is usually about relationships, either not maintaining ones or holding on to grudges or caring too much about what so-and-so thought, just not really embracing their own life and their own opinion and kind of either holding on to something or caring too much about what the neighbors thought, things like that.
Yeah, I feel that one about, realizing when you are healthy, just making more of that is something which definitely hits me a lot more. And really when that hit me was a few years ago when I saw a young woman come in with pancreatitis, right, in her 20s. And you think, okay, pancreatitis, she doesn't look too bad. Let's get an ultrasound, figure out the cause. Are there gallstones there? Let's see what's going on. Within 3 hours, this young woman's in the intensive care unit. She's intubated, ventilated. Next day, she's passed away.
Oh.
And the family, I had to go and break the news to the family because she was under the care of the surgical team and they wanted an update about what happened. I'm going in and, into that relative's room and just hearing this scream, the guttural scream of the mother, it just stuck with me forever. And she was in her 20s, no other medical conditions. And that just made me think like, wow, I'm in my 30s now, I'm 34, life can just go in a flash. So yes, truly don't take it for granted. We sometimes have this tendency to walk around like we're immortal and immune to things. And, we're really not.
No, we're really not. We're really not. I always think that personally contemplating my own mortality truly helps me live. And I really do try to practice that on a daily basis, and not in a morbid way or a scary way, but in like a freeing way. And what it does is I don't do it to be like, so now I have to travel the world and like jump out of airplanes. I do it like on a daily basis. Like I can appreciate my coffee and how it tastes, like how the sun feels on my skin when my mom calls me on my phone, things like that. Like that's what I try to like thinking about how that's all going to go away. That's inevitable. How can I appreciate it now? It like helps me be in the moment. It helps me be here today and appreciate my little life that I love so much,
Do you feel that faith and religion influences someone's perception of death and how they handle it in a positive or negative way?
I have seen that. I do think people who have some sort of faith in anything, it does seem to help their life while they're still here and help their death. I have seen it sometimes affect things negatively, when they're kind of like hyper focused on it, or really hoping that God will like save them, or like we're not going to talk about death because I believe in God and only God can tell me when I'm going to die, which is great. And I've seen that really hurt people, because then they don't ever like address that they're going to die because they think they're not going to. So I've seen stuff like that, which can kind of negatively affect how their death goes, because they live in this like state of denial. But generally speaking, and doesn't have to be a certain faith, any kind of faith in anything, even like faith in humanity or something, right? Any kind of like faith that they're taken care of in some way, seems to help. But I also have people who have no faith, and they also did fine as well. But I do think people who have some sort of faith seem to have like a better perspective sometimes.
Yeah. That appreciation for life, I guess, maybe, or gives them some additional comfort that they might be going somewhere nice. Maybe.
Yeah.
As a hospice nurse, what is one thing you wish everyone knew that they don't know, probably, about death?
Talking about death will not make you die any sooner. It will help you live better. It will help you live better and die better. And hospice isn't about death, it's about life. And I truly mean that. I know that can sound cheesy, but I mean it. I mean, it's about living. It's about living.
You know, I feel that our ancestors or the ancient cultures used to have a better appreciation for death than we do. And I don't know why that is. Like, the Romans used to have little coins or tokens, when they're sort of talking about death and thinking about death. And if you think about the ancient Greeks, when they'd place some, coins upon, someone who's dead, so they allow them to pass the river Styx, and go into the underworld. And I just feel that the culture and talk about death was a lot richer than it is now, and it feels, I don't know at what point it became so taboo, but it really does feel that way now.
Yeah, I mean, I think our medical system, not in a bad way, it's I mean, our medical system is great in many ways, but even like in the 1800s, like our loved ones were dying in the home. Death was not like hospitalized far away. People were dying in the home, and their families were caring for them. They'd have wakes in the home. Once someone died, they would like dress their house in black ribbons. They would dress in black, so they knew that this family, this house is in mourning. So then the neighborhood would come over and like help the family. So I just think it was like more in our face a little bit. It was more like our responsibility to care for our dying versus taking them to the hospital to make them not die, right? Again, there's like pluses and minuses. I sound like I'm like, it was totally anti-hospital. That's not true. We do wonderful things there, and people do live longer because of that, and that's amazing.
In the 18th and 19th century, the obsession with death was almost morbid, for want of a better word, because I remember they used to have these death masks. When someone died, they'd make a plaster cast mask of their face and actually hang it in homes.
Yes.
And the Rhesus Annie, the CPR doll, is based off the death mask of the unknown girl who drowned in the River Seine in Paris.
Wow.
This young girl died in the River Seine. Her drowned body was found, and the mortician, was really enamored by her kind of half smiling dead face, made this cast of her face. And eventually, one of the Leerdal, I think it was, this kind of Belgian toy maker, he saw that face, he liked it, he wanted to use it for, the CPR dummies that he was making, and then now here we are. Because of death, we've got this CPR doll who's then gone on to save millions of lives.
Wow. I know people used to like save hair and make jewelry. There are many photos of dead people, like propped up dead children with the other like alive children, so they could remember. And it wasn't a weird thing. It was like, that's what people did.
These death photographs. Yeah, I saw that. And I just thought that's really creepy stuff. But maybe it was a thing back then where it was actually quite warming that you'd have this memory of someone with you, right?
Yeah.
And I think even in, I can't remember exactly which tribe or which country, but somewhere in Southeast Asia, they just kind of dress up their dead like skeletons and stuff. And they just kind of, put cigars in their mouth. They put like baseball caps on their head and they just kind of chill with them for the day. And then they bury them again.
God. Wow.
Wow.
Hey, you know what? I'd rather that than like us hiding it all away. It's like, yeah, it should be an open thing. I think it would really help us. I think it would really free us a little bit. It takes some time to get used to, but free us a little bit on this, becoming just a little more comfortable being around death and dying, talking about death and dying.
I think you do a fantastic job online in breaking the ice and talking about this stuff and, just even this conversation, hopefully it's enlightened people to go out there and, live more intentionally, talk about death a bit more, and hopefully that will help them live better. So Julie, really, thank you so much for coming on and being so open about death.
Thank you. Thank you for having me. It's my favorite topic, oddly enough.
Thanks again to Julie McFadden. So, do you still fear death now? How has this conversation changed your perspective on death and dying? Let me know in the comments. And make sure you subscribe so you don't miss the weekly Dr. Karan Explores podcast. And I'll see you organic sentient meat suits next week.